I'm David Playford, Professor of Cardiology at the University of Notre Dame in Western Australia and the Principal Investigator of the National Echo Database of Australia. And what I'm presenting is some data that we have derived from the National Echo Database on preserved ejection fraction and structural heart disease in 448,848 patients. So that we know that there are clear benefits on treatment for heart failure in reduced ejection fraction, but it appears that those benefits are greater in men than in women. But there's no really clear evidence for benefit in heart failure with preserved ejection fraction. But there is a possibility that women benefit greater than men. And so data from TopCat and Paragon HF suggests that perhaps women more than men may benefit from these treatments, and that requires a little bit further investigation. So there seems to be an inequity between men and women in the diagnosis and treatment of heart failure with preserved ejection fraction. So our main aim of the study was to look at the proportion and characteristics of men and women who present with the potential heart failure with preserved ejection fraction based on Paragon HF criteria that we were able to extract from the National Echo Database of Australia. And as far as the criteria are concerned, the Paragon HF criteria, to remind you, is preserved left ventricular ejection fraction is an LVEF greater than 45%, measured using echocardiography. Left ventricular hypertrophy is measured using a left ventricular septal dimension of 1.1 centimetre or a left ventricular posterior wall dimension of 1.1 centimetre. Anything greater than that was regarded as LVH. And left atrial enlargement had a number of criteria: left atrial width of greater than 3.8 centimetres, left atrial length greater than 5 centimetres, left atrial area greater than 20 square centimetres, left atrial volume greater than 55 mils, and left atrial volume index greater than 29 mils per metre squared. So the National Echo Database of Australia is a national registry of echocardiography that links individual echo measurements with mortality. We extract individual measurements as well as the interpretive text data from cardiologists around the country of Australia. And we have 23 contributing sites to this database at the moment, and the NEDA version 2.0 database is built from a unique process of engineering that has a data linkage process that links with the National Death Index of Australia. So we use this database to extract data that would be suitable for this particular study. So the NEDA 2.0 was extracted on the 1st of January this year, had over 1 million investigations on 631,824 individuals, representing 299,000 women and 332,000 men. And we had data from 1985, but we did actually cut off the older data so that we only extracted those who were after the 1st of January 2000, so we had a more contemporary sample. And we also removed 151,000 cases where the exact ejection fraction wasn't calculated. So we had really only exact EFs in this database. And then we removed a small number of cases where the echo was after our census date. So that was 470 cases in total. And that gave us a sample of 493,155 individuals aged over 18 years with a median age of around 63 years and interquartile range 49 to 75 years of age. And 725,000 echoes with the first or repeated ejection fraction within 6 months or greater than 6 months apart from each other. So that gave us an extraordinary amount of follow-up of over 2,000 days from the first echo. So from that sample, we then split it into males and females, and there was 237,046 women and 256,109 men with similar ages. Women were very slightly older, 61 years versus 60.6 years for the men. But there was a very clear difference in the ejection fraction in this group. So the left ventricular ejection fraction for women was an average of 64 percent, plus or minus 11.4%. And for men, that difference was a mean of 59.5%, with a 95% confidence interval of 13.5%. And so that means that basically, with an ejection fraction less than 50% in women was 8.3%, whereas left ventricular ejection fraction less than 50% was 17.6% in the men. So a very significant difference there. And overall, that sample had 119,232 deaths, with a 5-year case fatality rate of 18.4%. So what I've done here is I've got the analysis for men and women separately, and you'll see that there are quite significant differences between them. So in female cases categorized by left ventricular ejection fraction, in those who met Paragon HF criteria, so left ventricular ejection fraction greater than 45%, there were 223,512 women in this that met these criteria. And just to remind you that the Paragon criteria were LVH, based on a septal posterior wall thickness more than 1.1 centimeters, left atrial enlargement based on the criteria that you can see up on the screen, structural heart disease, which was the combination of those, or valvular heart disease, had moderate or greater valvular heart disease. So you can see that those with an ejection fraction greater than 45% tended to be a little younger. They tended to have a body mass index very slightly more, not really significantly different, but they had a lower estimated right ventricular systolic pressure. The ejection fraction was higher as expected, and they had a lower level of left ventricular hypertrophy, left atrial enlargement, and structural heart disease. We had very good follow-up for all of these individuals. Then moving on to men, the categorized again by left ventricular ejection fraction. There was 223,000 with an LVF greater than 45%. Age was slightly less again. Body mass index very similar. The RBSP was less than those with the ejection fraction less than 45%. And again, they had less left ventricular hypertrophy and left atrial enlargement than those with an impaired ejection fraction. But you'll note the obvious difference here between the men and the women in this cohort. So going through that in a little bit more detail, if we take the age distribution of structural heart disease in women, those with an LVEF greater than 45%, then there were 30.8% of women who had left ventricular hypertrophy based on the Paragon HF criteria, and 35.3% of women who had left atrial enlargement by Paragon criteria. And then if we cut that down by age, you can see that that as individual women were older, there was a much higher proportion of those who met Paragon criteria with left ventricular hypertrophy, left atrial enlargement, and preserved left ventricular systolic function. And even in those who had a definite confirmed diagnosis of heart failure, which you can see on the small insert on the screen, those people were still very likely to have evidence of structural heart disease based on Paragon HF criteria, in fact, even more so than those that didn't have a prior diagnosis of heart failure. If we move on to the same analysis, but for men, you can see that 87.2% of men had an LVEF greater than 45%, but 50% of men had left ventricular hypertrophy, and 42.9% had left atrial enlargement using the Paragon HF criteria. And again, there was this age-related change, that those that were older had a more likely diagnosis of structural heart disease using Paragon HF criteria. And again, in the insert, you can see that even if there's a known heart failure diagnosis, there was a high probability of having a very significant amount of structural heart disease based on the Paragon HF criteria. So looking at this in another way, if we take all female cases, so on this particular slide on the left-hand side, it's 237,046 women, LVEF greater than 45%, those with LVH by Paragon criteria, and then looking at the different forms of left atrial enlargement that allowed them in based on the Paragon criteria, then overall, approximately 50% of all individual female cases would have potentially been eligible for Paragon. Now, noting, of course, that there are other criteria, but purely talking from the echocardiographic perspective, we've got a very high proportion of people here, not all of whom actually had significant structural heart disease, but those that met the criteria for Paragon HF. On the right-hand side of the screen, you can see that that even in those with a confirmed diagnosis of heart failure, 57.9% of these individuals would have been eligible for Paragon based on the echocardiographic criteria. Then the same analysis in men, 256,109 individual men, 87.2% had an LVEF greater than 45%. And then going through the same thing with LVH, left atrial enlargement, and the overall structural heart disease prevalence, then there would be 61.4% of men, of all men that were in this NEDA cohort, that would have been potentially eligible for Paragon and fit the criteria. In those with a confirmed diagnosis of heart failure, 51.9% of them would have been eligible for Paragon criteria enrollment in the trial based on the echocardiographic criteria. So based on the data that I've shown you today, then if we apply just the echocardiographic Paragon HF criteria for structural heart disease to those with a left ventricular ejection fraction greater than 45%, we identified that there'd be many eligible patients that would potentially fit into the trial, with more men than women. And so we believe, based on this data, that Paragon HF criteria on their own may actually overestimate the prevalence of structural heart disease in this group of patients. And of course, we need clinical trials that had more rigorous structural heart disease and sex-specific criteria to see if this actually matters from an outcome perspective. Now, I just want to add a couple of important limitations, and that is that we have not linked with hospitalization heart failure. This is the known heart failure was based on the reason for referral, and we don't have NT-proBNP, which is one of the criteria for eligibility for Paragon HF. We are planning to get that data with our next iteration of NEDA. That'll be NEDA 3.0. So stay tuned. I'll hopefully give you an update on that one in the future. And we also have a limited cohort with confirmed heart failure, although they did actually have the same structural heart disease profile that I showed you without a confirmed diagnosis of heart failure. So what does this mean? I mean, I think one of the questions that this has to raise is that there is a possibility that there may have been a dilution of a potentially beneficial effect by including people that really didn't have significant structural heart disease, but got included based on the criteria of the trial. So the take-home message is that structural heart disease in an echocardiographic database is actually quite common. And the risk associated with that varies depending on the structural heart disease criteria. In clinical trials that include structural heart disease criteria, we have to be very careful about the inclusion criteria so that we're sure to make sure that we include people that do have significant structural heart disease rather than those that meet the criteria and may potentially not have significant overall structural heart disease and run the risk of diluting the potential beneficial effects of the drug.